And so you have a 40-year-old patient in a car accident, minimal movement of arms and legs at the scene. You assess him as a 45C. This is an incomplete injury. And this is what it looks like. So pretty gnarly, right? So there's a couple of things going on. It's broken in a couple of places, right? So a non-expert can see that there are some things with this CT that aren't right. You have fractures at different levels. You have potential dislocation in the mid-cervical spine as well. Gosh, how do you approach a patient like that? That's just showing some axial pictures through there to show the degree of fractures that are happening here. And this is an MRI showing that fracture at C2 and then lower down in the mid-cervical region. And surprisingly, the cord has some injuries. And it's always important to remember that, a lot of these scans, that's kind of at the resting point where the folks are getting a CT or MRI, and things have already happened. They've already hyperextended or hyperflexed and really dinged their spinal cord. And then they come back through elastic recoil to a resting position. And so this may not be as bad as it's ever been. So obviously you have to be very careful with these folks and C-spine immobilization. The spine, I think, is very fascinating. It's one of the things that is a majority of my practice, because my prior training undergraduate was physics and that kind of thing, and so the spine makes sense to me. It's biomechanically a really cool thing, in addition to carrying the neural elements. And so obviously it supports the head, the upper extremity and torso, it supports the body mass, transmits the weight to the hips. It maintains an upright posture. I think it's just really cool how the body tries to maintain the head over the shoulders, over the pelvis, with this neat sort of alternating lordotic, kyphotic, lordotic spinal arrangement. It allows for mobility, flexibility, all while protecting the spinal cord. So to me, the spine is a neat thing. And so generally in the trauma patients, is there a neurologic injury? Is the spine stable? That is from a surgical standpoint, right? It's from a neurosurgical viewpoint with carpenters. If there's something to fix, we should have a reason to fix it. And so do the neuroelements need to be decompressed, or is that injury already happened and it's not compressed? Is it stable? Can I brace it externally? Does it need surgery, front, back, or both? So these are all kind of quick questions. And for the patient that we showed about, there was neurologic injuries, 45C, and the neuroelements need to be decompressed because we saw that crazy MRI. And is the spine stable? No, it's fractured, it's dislocated, very unstable, can't brace it. Well, I guess you could, but it's not really the standard of care. And so, gosh, what do you do? This particular patient needed both front and back surgery. This was actually a surgery that Dr. Crandall did. First, they did a C2 to T2 laminectomy and fusion. It's just kind of showing the alignment of the screws on the intraoperative philography, both AP and laterally. And so this is showing the first stage really is to decompress that spinal cord, which we can see in the MRI on the right-hand side, and at least provide stability. We can't see them here, but those screws are running all the way down from C2 to T2 out laterally. So there's stability now. Now it's not optically pleasing, right? So we still see something's amiss. And so there's more work to do. And so had an anterior surgery that shows just a post-op x-ray with the ACDF plate that's in place. And then you can see the alignment is much better through that. And that area can kind of heal with the bone graft that's in there.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.